Wonderful. Thank you. Well, and thank you all for being so curious and having so many questions. So we have a number of questions that Dr. Alvarez and I will do our best to try and get through. But I think we will also probably be doing a Q&A session recorded, posted on the internet to address any questions that we don't get to today. So if you don't hear your answer from us today, please do check back to the website, and we will hopefully soon have a recorded video that addresses the ones that we couldn't get to just because there's so many questions today. And so I think I'll get started. And I'm gonna choose a big topic to start with while I'm fresh, which is fatigue. Many questions were submitted about fatigue, how to manage it, what medicines to use, why it happens. And so I'm gonna try and talk to that, and then I'll let Dr. Alvarez contribute as well. The analogy that I like to use when I'm talking with my patients who are saying, why do I have this overwhelming fatigue like a lead blanket in the afternoon, is that of sort of energy deficiency. So go with me on this analogy for a second. So we're going to think about your brain as a network similar to all of the roads in and around the Denver metro area. There is a direct route from, say, Littleton to DIA. Sort of direct. You get on the highways, you go on 470, 225, and so forth up to Pena, and you get to the airport in a reasonable time. But what if that network has a blockage? What if there is an accident on 225? You're still going to get to the airport, but you have to get off the highway, take a side road, connect to a different road, go down to the next exit, get back on the highway, and then on you go. What if there are two accidents or two things impairing that direct route from Littleton to DIA? You're still going to get to the airport, but it's going to take more gas and more time because you're going to have to do the same thing twice. So your brain is a much more complex but similar network in the sense that neurons connect to other neurons, connect to other neurons. So it's all about getting the signal from one place to another. So with MS, if you have blockages in your network, if you have had lesions, if you have inflammation that's slowing things down, you're going to spend more energy doing something that otherwise would happen pretty easily. So you're kind of spending that energy in your tank and ending up with fatigue that's going to be more than someone else without those blockages. That's one explanation for MS fatigue. And I hope you followed me on that analogy. But there are many other things. There are the impairments that we can see in gait. That again, maybe you can walk, but it takes more energy because you're having to work harder because your leg is tight or spastic or weak. Maybe you're not sleeping well because of spasticity or pain. If you're not sleeping well at night, you're going to be tired during the day. So the constellation of what contributes to MS fatigue is complex. It's more than one thing. The treatment is more than one thing also. So first of all, we point to the lifestyle things first. So there's no magic bullet. I wish there were, and if there were, I promise I would give it to you. But the lifestyle things that we need to turn to first are things like diet. Are you eating vegetables? Are you drinking water? Are you having meals that are free of preservatives? Like all of these things that, yeah, everybody should be doing that. We all need to. Those are foundational. So lifestyle things, sleep, diet, exercise. They've actually done studies showing that exercise is more beneficial to MS fatigue than it is detrimental, even though after that period of exercise, whatever you do, you may be disagreeing with me. Like over time, exercise is better for MS fatigue than medicines. And I saved medicines for last because this is one of the most common questions that we get, but I don't want to jump to that before acknowledging that really the other lifestyle things are foundational and those need to be in place. Those are really and proven to be the better treatments. But the medicines that we use can be helpful for some. They come with risks. Again, everything in life is a balance of risks and benefits, and the medicines that we use for fatigue are no different. And so we need to modify those risks if we're going to try a medicine to help with MS fatigue. And just to temper expectations, it really is not a magic bullet. Some people say, I'm still tired, but I feel now like I've been caffeinated, tired person. It isn't that it's going to take away all of the MS fatigue. So, Dr. Alvarez, anything to add?
I got nothing to add. That was awesome. Perfect.
Okay.
We had a cluster of questions around natalizumab or Tysabri, so I'm going to address a few of them just to kind of change gears for a little bit of a different drug. There's a question for somebody who must be a reader because they saw that sub-Q Tysabri is a thing in France. It's a thing in Europe. It got explored in the US, but the FDA requires that when you change sort of how you give a drug, how you pick up drug concentrations, all these other things are different. And so they required a whole trial to explore that further. And the company just decided not to do a whole trial to get that into the market in the US. So as far as the sub-Q option, I don't think will be coming anywhere to an infusion center near you. There was a question around the JC virus and talking about the severity with a high titer. So just emphasizing a little bit, the JC titer, there's an antibody test, serology. It often gets confused with a PCR, which looks for the actual virus versus antibodies to the virus. Unfortunately, we all pretty much have the JC virus. It lives in your bladder, it swims happily ever after, and it lives a long life there. But it requires a few mutations to get to the brain to cause that brain infection called PML. So a higher titer on the antibody test probably indicates that the virus is more active. You respond to it a little bit more, creating more antibodies. And therefore, because it's more active, it has more of a chance to make those mutations that can go to your brain and cause the infection. Any PCR test is bad. It tells you have the brain infection. For the antibody test, it doesn't mean much unless you're on a drug where it matters. And predominantly that is for Tysabri. All right.
Okay. All right. I'm going to take a question from today then. Are Kesimpta side effects the same as Ocrevus? And are the risk benefits the same? The risks of injection versus IV. Yes. So I will address that broadly. So both Kesimpta or ofatumumab, which is the generic name, and Ocrevus, ocrelizumab, are B-cell depleting medicines. It is their job to find those B cells in a patient's body and destroy them. Just get rid of them. It's not a very sophisticated thing. It finds those cells and it takes them out. And it takes them out because that's a really effective way of treating the inflammation of MS. If you don't have B cells, the rest of your immune system is still intact, but it's kind of like chilling out. It doesn't have anybody sort of poking it saying, go attack, go attack, go attack. And so both Ocrevus and Kesimpta work in the same way, but they're delivered differently. Ocrevus every 6 months as an infusion, Kesimpta, other than the first month, every month subcutaneous. So the side effects are similar, but they are different. Whereas 1 in 3 people getting the Ocrevus infusion can kind of feel sort of crummy, particularly in the early infusions, kind of like hot, itchy, uncomfortable, maybe a little feverish, maybe a little scratchy throat. That tends not to happen as much with the ofatumumab, with the Kesimpta. The Kesimpta is a medicine working in the same way, but you're getting smaller doses at more frequent intervals. You can still get those side effects, but it's less likely. The benefits are very similar between the two drugs because, again, they're doing the same thing. They're just doing it in different mechanisms. And are there risks of sort of infusion versus injection? For some, for any injection, it doesn't really feel good to poke yourself. So there is that pain. There can be a localized reaction, kind of an irritation in the area where the medicine has been injected. That's a little bit different when you get an infusion, since in that sense, the medicine is going directly into the blood. So I hope that answered the questions.
I'll piggyback a question on that question a little bit, just because you were explaining sort of how B cells work around the BTK inhibitors and kind of saying if you're transitioning from B cell depletion to the BTK inhibitors, do you need to let the B cells come back so that the BTK inhibitor can work on them? Again, well, these are proposed mechanisms. So meaning this is how we think the drug is working. There still needs to be some research to try and understand where the drug is working. Because part of the thought is if it's not really working on relapses and inflammation, it's probably not working at the B cell level. So one thing is what works in the quick and dirty, right, in the lab and a Petri plate, and a little glass dish or something like this, versus kind of what's working in the real world. And I think that that's the challenge that we have is we can test things without any animals. Eventually, we might have to go to animals because we learned that sometimes things just don't pass that smell test. Then we have to go to humans. And then as we've learned from some of these trials, we recognize that, hey, just because it was the best of intent, it might have worked on the smaller trials. It didn't work at the big level. And so, again, I wouldn't worry too much about the drug not working because if you're taking it continuously, your B cells will eventually come back and have an effect on them.
Dr. Alvarez, would you like to talk about cannabis?
Always. So cannabis got approved, I think, shortly after I got here, and I had to do some quick learning, I think, as a lot of people were moving to the state just to get access for it. I think one of the nice things in recognizing maybe where a lot of our drugs come, they come from plant products, right? So if you take aspirin, it's probably easier to take an aspirin than to chew on willow bark, which is where aspirin comes from. I will do that in a heartbeat. So I think from these products, trying to do the more refined products, and how to do that. So that usually means trying not to smoke it. If we take tobacco, nicotine's not a problem. It's the coal tars that kind of go with it. With cannabis, trying to get the more purified products, meaning sort of oils or edibles or things like this tend to be a little bit safer than sort of smoking. Vaping might be a little bit safer than smoking with less of that smoke. THC, CBD, all the other stuff that's in cannabis might have some pretty good effects as far as spasticity, helping with sleep. For certain other patient populations, sometimes gaining weight. That's usually not a problem for most people. But, in cancer patients or things like this, sometimes they've been used for that purpose as well. So there are some known useful benefits to cannabis.
Thank you. I'm going to take a straightforward one. Is Aleve or naproxen a recommended pain medicine? So this is a good pain medicine, and we recommend it a lot for a variety of different concerns. The mechanism by which it works tends to be more effective for musculoskeletal type pains than the pains that can come from nerve problems. And so if you're taking Aleve and it's working for you, I think that is just fine. But if it's not working for you, it may be because your pain is coming from nerve problems, not from bones and muscles. And then there are a separate category of medicines that we use for that type of what we call neuropathic pain. But yeah, Aleve is a safe pain med. if I may, I'll jump on to the next topic is fertility and family planning, which is huge and deserves some time to kind of dive into. I will put out there that Dr. Anna Shaw is our expert, and she's not here right now, but I will do my best to answer that. So the question is, how does MS affect fertility and family planning? So, and then secondly is sort of, is MS heritable? Can you inherit it from your parents? And so I'll address the first question first. So there is no impact on fertility from the MS medicine itself. So women still produce the same number of eggs, men produce the same number of sperm. There's no impact to that. But it is a complex topic because some of the medicines that we use have implications for pregnancy. We don't use a lot of teriflunomide, but that is one medicine, for example, a pill that can be used as a disease-modifying therapy, which is not good for babies. And so there are different aspects of fertility that we like to talk with our families, our moms, about in consideration of getting pregnant. There are also sort of best practices in terms of when to plan a pregnancy if you have the luxury of planning, if you're on an infusion or an injectable medicine like Kesimpta. But there is, I want to sort of underscore, it is not only possible for women with MS to get pregnant, but if that is a path that you are choosing, we will help you to get there. It is not the path for everyone, but if that is something important to you, we work with you absolutely to make sure that that is part of your goal. So there's that. The second question about heritability is something that actually Dr. Alvarez and I and others are studying, called the Rise and Dream study, which is looking at first-degree relatives of people with MS. And I can talk more about that, and I know Isabel can talk more about that. She's right outside that door later and right in the back. So what we know from large studies of people with MS, looking specifically at their genes, is that there are at least 236 very small changes in the genes that are more likely found in people with MS than people who do not have MS. So we know there is some genetic component to MS, but it's not as slam dunk as my mom and dad both have brown eyes, so I'm going to have brown eyes. Or my mom has MS, so I'm going to have MS. We know there's an increased risk for first-degree relatives, but it is not at all a certainty. In fact, it's still pretty darn unlikely that any first-degree relative of someone with MS is going to end up with MS. But they have an increased risk. And so what I often counsel my adult patients about when they ask about what can I do for my children, well, then we focus on things like modifiable risk factors. What does that mean? Well, it means making sure vitamin D is in a normal range, making sure that they grow up with exercise as part of their life to maintain a healthy weight and active lifestyle. Make sure that they grow up in a home without smoke, because we know that's a risk factor. Again, are any of these one things the reason? No, absolutely not. It is far too complex. If it were that straightforward, this guy would have figured it out a long time ago. So it's a very complex picture. But for if you are a person with MS thinking about risk for your child, I would say let's focus on those things. Let's make sure that vitamin D is normal. They have a healthy lifestyle. They're not smoking, and go from there. Okay.
Yeah. I'll do a quick one and then we'll get into a big topic. We got asked about ivermectin as far as a treatment for MS. Forget it. Won't do much of anything for MS as far as the data that we have for so far. And then I got a cluster around aging questions. So I'll try and address them all. They were all kind of very individualized. So I'll try and just kind of touch base with it. It is true that most of our clinical trial data does not include patients over certain ages. That age is close to almost 50% of our patients. The average age in our clinic is about 48, 49. Older patients don't necessarily make it in. So probably half the patients in the US are probably over the age of 50. Some of the trials cut off inclusion around age 50, 55. Now, there are efforts recently to try and increase that age, and especially for progressive disease, where they're starting to kind of go up to 65. This is part of the reason why clinical trials are great for certain things. It's a very controlled environment. You can adjust things. But we need real world data where sometimes there's maybe a lot of biases in how we do it. But for example, that effect that I showed on age was everybody in our clinic, regardless of age. So it was just people starting drugs. So being able to see that difference, and it's maybe to kind of highlight that difference, I showed that the crossover point between these drugs in our study was about 54 and change. If you look at clinical trials, that crossover age is around 40, 42, if I remember right. So by looking at older patients, you see that older patients still have inflammation. 5% of MS patients get diagnosed over the age of 60. So it is a thing. It is a fairly common thing, I would say, especially as we're starting to kind of diagnose patients with MRI and other things like this, and just being more aware of the disease, much kind of like the pediatric population. So some of the things from trials can be extended, I think, into this older group, but sometimes we do need those real world studies to kind of say, does it still apply there or not? The tolobrutinib thing with the liver damage, will older people have more liver stuff? We won't know until we start doing it. The alternative is to say, yeah, you can only start drug if you were under the age of 55. So sometimes, we don't want those restrictions necessarily placed, and we think that the drug applies, but we need to kind of see what that looks like. And that's a lot of times what they'll do, the phase 4 studies or kind of these real world studies to kind of evaluate those things a little bit more so. So as far as why they get eliminated might help answer some of these questions from the clinical trials. So the earlier criteria for MS removed MS patients because we didn't even have MRIs. But when people died and we looked at autopsies, we said, hey, those people that died older, we have to worry a lot more about strokes and other kind of conditions. So let's look at younger patients so that we can kind of, for at least clinical trials, look at a more pure population for these drugs whenever we would get drugs, because at that time there were still no drugs, that we could kind of then apply to see what the effect is. Because these drugs probably won't work on stroke or other things that happen in older individuals as well. So there was a reason to the madness. I think it's still sometimes helpful because you start to see that worsening versus progression component to it a little bit more so, right? To have arthritic changes that affect the knee. I'm looking forward to 2 months from now when I turn 50. And this year, for people that know me, I had a broken foot and needed surgery. It's been, a learning lesson, I think, for other things that can kind of happen. Thankfully that's recoverable. And so we'll have to kind of see. But there's a reason for some of these things, and why we try for some studies to kind of enrich for certain populations. So at least see if there's a signal to why we're trying to do some intervention or drug or things like that. Do you want to touch base a little bit on RIS?
Yeah. Do you want to set the stage with our new diagnostic criteria?
Yeah. So radiologically isolated syndrome. So before you have symptoms, and sometimes you pick it up on MRI, we might see that there is, changes on MRI that look a lot like MS. Now I look a lot like MS because I got a lot of lesions that look like MS, or I look like MS because I have one lesion that maybe looks like MS. So there's a big spectrum, right? So for the RIS, to try and kind of define what it is, the early definitions made it look, I mean, the MRIs had to look like MS. I mean, like you had to have multiple lesions, you had to see new lesions coming up before you develop symptoms. And even then, until you had symptoms, you couldn't call it MS. The new criteria probably started allowing some of that RIS to become MS. How far early on, we're still trying to figure out what those criteria will look like. But for example, the study that Teri was alluding to with first degree relatives, we're seeing some patients with one or two lesions that look like MS. The genetics might look like those in MS as a population. But what do we do? When do we start to treat? Those kind of questions are still going to be real questions.
Yeah. And there is some disagreement, although I would say most people are kind of coming on board with RIS. If you meet specific criteria, is actually just MS. You just haven't had a clinical attack yet. People are coming on board with like, yeah, we probably should treat that. We should use MS medicines for the patients that we are diagnosing with this radiologically isolated syndrome, because it's just a matter of time. And the inflammation is there. The inflammation is causing damage. And again, your brain is your precious resource. We need to protect that. And so I would say that is my bias, and maybe our bias is that RIS, again, if you meet specific criteria, is MS, and we need to protect by using medicines to do that.
I might take the last question here, and I left it on to the last on purpose. For people that know me, I might not be the most politically correct person, but I thought that this is one of those that sometimes we just need to address a little bit, and I'll try to be politically correct. But can you talk about the future of MS research in light of the potential threatened cuts to federal medical research funding? So I think we are in a country that has spent a lot of money on research. I think that if you do take a step back, the US pays for a lot of the research and a lot of the drug development that happens around the world. Undoubtedly, that cannot be argued with. I think the answer might be to get other people to pay as much into research as the United States does. Cutting funding might not lead to a much better world. This costs money. Right now, pharma pays for most of the research that we talked about today. But for things that are in the early stages of development, it all comes from the federal funds. For the most part, a lot of the research comes from there. I think what projects and things like this have to get evaluated and kind of go through a process. There's a very sturdy process that goes into what studies should occur and which ones don't. And I think interfering in that process is going to basically affect how well some of these questions get answered. We've had about almost 40 grants cut from the university due to language issues. An example of one of them, I think, is very pointed, not in the MS space, but was looking at headaches. We know that headaches occur more in women than men. And so there's a hormone component. A lot of headaches occur around periods, for example. And so the question posed, if you have trans individuals who are taking then hormone supplements, it provides sort of a very good hamster model, if you want to call it that way, to see what the effect of hormones might be. Because it was done with individuals that are trans, we will not find the answers to that. It was not proposing that patients undergo trans conversion to try and understand this question better or not, but the misunderstanding of sort of being able to learn to something that is happening currently, unfortunately, we will not find the answers for this. One of the big areas that has been affected or is under the courts, so we've not seen it yet, is indirect funds. I'm not sure I understand indirect funds well, but indirect funds are basically when we apply for federal grants, there's an agreement between the federal government and other institutions that sort of kind of put a tax or an increased amount on those funds, and it's prearranged and it's worked out years in advance with the institutions. If you live in New York City, Boston, more recently Denver. They're expensive cities. It costs more for those areas to do research than it does in other areas. When you apply for a grant, you're paying for that research, but you're not paying for the buildings that we're sitting in currently. That gets paid for a lot of times by indirect funds. Cutting indirect funds will mean that we're probably going to have to do research at some point when the buildings break down outside in the parking lot or things like this, because we won't have the buildings to do that. We're not going to have the resources to be able to do things that will allow us to have the infrastructure to do that research. So I apologize for that, but I think it's just important to understand that that money is not going, for me to have a yacht trip. We don't have a pool of vehicles, at the institution level to be able to go around and take vacations or things like this. Those funds are earmarked for a lot of the infrastructure that allows us to do that research.